Hi, hello, this is Module 5 of Complex Disease Management. It is chest assessment. So we are, for chest assessment, you're going to do a chart review. You're going to do observation. Let's see if I can get this twisted around so it doesn't look crooked. Chest review, chart review, observation. You're going to feel the patient, do some measurements, and you're going to listen. A hands-on assessment will really give you uh, additional information that you need to know for. I'm sorry, there's a bee. There's a little sweat bee flying around, and I don't want to get stung. Uh, Hands-on assessment will give you additional information about the patient that you need to know for the deep breathing exercises, for the tactile cued exercises, deep breathing that you want to do with your patient, and it'll teach you what it'll give you a better idea of what they are doing from the inside. So on the next page, you want to do a chart review. Look at their prime. It's the handout says primary and secondary diagnoses, but go ahead and look at them all. Try to get a picture of what's going on with this patient. All the diagnoses that impact, like I've talked about before. Don't just blindly go down and copy their diagnoses. Try to get a picture of what's going on with the patient. COPD, CHF, diabetes, history of UTI, sepsis, what else, hypertension. Try to get a picture of what's going on with this patient at home, what their life looks like. How active have they been? Try to get in your mind, how long has this been going on with the patient? So what is their overall health level? What's their activity level been like in the past 6 months, year, 5 years, 2 weeks? Look at their vital sign progression, and if there's not documentation of it, their vital sign progression, they're in the facility, or if you can look back through their hospital records, what has their blood pressure been? Has it been steady? Has it become more hypotensive as they've laid in the bed more? What about during their therapy? Look through those records, real quickly. Get an idea of what their vital signs have been if they've been recorded. Have they had phonation or swallowing problems? And this is where, if it's not recorded, pay attention. This is for all disciplines, PT, OT, and speech. Listen to the quality of their phonation. Can they say a whole sentence? Is their voice weak? And if you notice that their voice is weak, you could ask them, is this how your voice usually is? Has it gotten weaker? Is your voice usually real quiet like this? Have you had any swallowing problems? Have you noticed that you cough more? Do you choke a little when you take a drink? What about when you're looking at their list of medications? Look to see pain meds, sleeping aids, antipsychotics. This might affect their respiration. Check their nutritional status and their hydration. If they have difficulty breathing, you might notice that their PO intake is decreased because it's just too much trouble to eat and breathe at the same time. So they're going to choose to breathe over eating. So they might have a weight loss. What about their hydration? It might not be documented in our charts. So you might have to actually do the pinch test where you put your do the tenting test on their forehead or their sternum to see if their skin has an automatic rebound, or is it slow. And if it's slow to go back to flat, that's an indication that they have some hydration problems. If they have pulmonary function tests or arterial blood gas results in their chart, look and see what that's looking like. Cough and sputum history. I don't know if that will be in the chart. You might have to ask them. Do you cough a lot? Is that typical for you, or is it just developed in the last month, 2 weeks? Ask them. And is it easy for you to, when you cough, can you clear everything out? And you may ask them, what color is it? Is it usually clear? Yes, but over the last 2 weeks or before I went in the hospital, it really got brown, yellow, whatever. Environmental or industrial exposure. I asked them about what kind of work they did, not just about smoking. There's I guess I call it a hang up, because there's so much more than just smoking. Did they work in a dusty environment? Did they work in construction where they were around a saw, sawdust all the time, or dyes all the time? And a chemical plant where they exposed to asbestos, silicone. Their psychological status, their psychosocial history. That has an impact, may have an impact on the support they'll get after discharge, may have an impact on their motivation, their history of commitment to a goal, and their ejection fraction just gives you an idea of their heart's ability to motor the power for the pump to motor all their functions. And normal ejection fraction is at least 55%. So if the lower their ejection fraction is from 55%, the more trouble their heart is having supplying the body with enough blood to perform its functions. Okay, so we're going to look at them. Sitting on the edge of the bed or the mat or in their wheelchair. Do they use oxygen? How much oxygen? Is it continuous? Is it PRN? And we may not be able to depend on what they say, because they may say, oh, I just use it when I need it, when actually they have a continuous oxygen order. Do they use a CPAP or a BiPAP machine? And I looked a little more into CPAP and BiPAP because I've heard of it, but I don't totally understand when you use it. So CPAP is one of is a positive airway pressure device, and they are used to treat breathing disorders. CPAP stands for continuous positive air pressure. They usually have a chin strap to keep the mouth closed so that all the breathing is done through the nose. CPAP provides a continuous stream of air at a predetermined level of pressure through a hose into the nasal passages. This continuous stream of air prevents the passages from closing off and keeps the soft tissues of the throat open as well. CPAP is used to treat sleep apnea, as well as patients that have neuromuscular diseases like ALS, Guillain-Barré, MS. Now, BiPAP delivers 2 levels of pressure, a high level during inhalation and a low level during exhalation. BiPAP is used to treat sleep apnea, and it can also be used to treat patients with respiratory disease and heart disease. Use of a positive airway pressure system keeps the patient from constantly waking up with breathing stoppages and prevents apnea from causing long-term healthcare problems like hypertension and cardiovascular problems. Do they use an abdominal binder, or might you consider using an abdominal binder? And to review why somebody might need one or be using one, it can help somebody who has weak abdominal muscles to help the diaphragm do what it needs to do, because if without strong abdominals, the diaphragm just kind of hangs out. Whoops. Sorry, the diaphragm just kind of hangs out there and doesn't have that, because remember, the diaphragm doesn't have any bony insertions or origin. It just inserts on the abdominal fascia. So if the abdominals are weak or overstretched with obesity, the diaphragm is not going to be effective. So an abdominal binder can give support to the abdominals and give the diaphragm something to contract off of. Another reason somebody might use an abdominal binder is low blood pressure, and the abdominal aorta goes right through the middle of the thorax, and the abdominal aorta is thick. It's about the half the thickness of my forearm. And if somebody has low blood pressure, you can use an abdominal binder to press the abdominal contents against the aorta and raise the blood pressure. So those are two reasons that you might want to put an abdominal binder on somebody. And then another thing is when you're sitting face to face with somebody, talking to them on the edge of their bed, sitting on the edge of their bed, you might ask them, what are some things that make you afraid in your breathing? So you're not asking them, are you afraid of spiders? You're asking them in relation to their breathing and activity. What are some things that make you nervous or make you apprehensive? Because maybe you can educate them and head some things off at the pass so they don't become barriers that a month down the line you find out whether or not they don't want to walk more than 10 feet because they had an experience once before when they walked to the bathroom, which is 15 feet away, they collapsed. And you can assure them that it wasn't because they walked more than 10 feet. It was some other factors. Maybe they had a UTI, or there was something else going on, or that you're going to be checking their blood pressure and their O2 sats, and you're going to make sure, take all these precautions to make sure that doesn't happen again. So get it out in the open what some of their apprehensions are related to their breathing, and address those issues. Look at their posture when they're sitting and standing. Are they kyphotic? So that's the curvature of the upper back. Can they move out of those positions? Are they lordotic, which means you should have a little bit of a curve in your lower back, but it shouldn't be, in layman's terms they call it a sway back, where it's just an excessive curve of the low back. Do they have a forward head? So do they move? Is the posture of their head way forward? It should, again, there should be a little bit of a curve in the neck, but the ears should be pretty much over the anterior shoulder. Are the shoulders rounded so that almost like there's a contracture of the pectoral muscles? The shoulders should be aligned over the hips, not coming forward over the. Let's say they shouldn't be drawn inward, so that the arms are in front of the body. The arms should hang at the sides of the body. And then the last point here is contractures of ribs 8 to 10, and you don't have to count down from the top 1, 2, 3, 4, 5, but it's the widely spaced ribs along the side. Just like any muscle can get contractured, the elbow flexion contractures, the wrist flexion contractures. If somebody is bent to the side in their wheelchair, or has had a stroke, or just out of immobility leans to the side, those muscles, the intercostal muscles, can become contractured. So ask them to lean to the side. Can they lean? And then I'm going to sneeze. Excuse me. When they lean to the side, can you get your fingertips between the ribs? Because there should be some space between the ribs. And just check that. Do they have mobility between the ribs? You have to have mobility of the ribs to be able to bring the shoulder to 150 degrees of flexion. If there's not that mobility in the ribs, if there's not that mobility in the ribs, you can't achieve full shoulder flexion. Look at their color. The tip of their nose, of their lips, of their nail beds. Are they blue? That would indicate they're cyanotic. There's not enough oxygen to go out to the periphery, because the body's always going to preserve oxygen for central and essential functions, for the brain, for the heart. So when there's a deficit, it's going to It's going to shunt blood centrally and away from the periphery. Are they white? Are they whitish? Look at the pull down the eyelids. Is it white? You can pull down their lower lip. Is it a real pale color? Are they anemic? Are they jaundiced? Do they have a yellowish tint to their whites of their eyes? A yellowish color to their skin. That would be jaundice, and maybe indicate lung cancer with metastasis to the liver, reduced liver function, like in cirrhosis. Look at how they breathe when you're talking to them. Is there the appearance of the difficulty to overwork with restful breathing? So is there overuse of the accessory muscles of inspiration? Are they unable to complete a sentence, which is usually 7-8 words? Can they not say an entire sentence before they have to take a breath, and they use the accessory muscles? Are there flared nares? Like, usually you shouldn't have to flare your nostrils unless you've run, and because that's a sign that you're really needing to take in extra oxygen. Is there a furrowed brow? That, the look of concentration. Sounds of breathing. Cyanosis or clubbing. So the cyanosis, we've already talked about the blue coloration. Clubbing refers to the shape of the fingernails. And you see, if I turn mine the right way, my fingernails turn outward a little bit. And another sign, let's see if I can get it in the camera the right way here. If I put my fingernails together, there, you can see a little window. They call that a little window in between my fingernails. You can see light coming in between where I have my fingernails together. Somebody with clubbing of their fingers, that is closed. There's not that little gap where the fingernail comes out of the bed, and it's a flattened appearance, and then the fingernail comes over the edge of the finger, more or less. So some people, it really is pretty definite where it goes over the edge of the finger. Some people are less so, but the real sign is that they don't have that. See if I can get it on my forehead again. They don't have that. When you put their fingers together, they don't have that window. It's pretty obvious. You don't usually have to ask them to put your fingers together. I want to see if you have clubbing. It's pretty obvious. People with cardiac, pulmonary problems, cystic fibrosis will have it. Some people have it, and it's idiopathic, which means they don't know why, but it's a sign. And again, it's just something to note. As you're in your observations, it's just another sign of cardiopulmonary difficulties, along with noting that they have used accessory muscles, they have a rounded back, that they have furrowed brow, flared nares with inspiration, shortened sentence length due to respiratory distress, that kind of thing. Remember that the normal respiratory rate is 12 to 20 breaths per minute. So if you notice that they are breathing faster than that, you would want to note that. Tachypnea / 24 breaths per minute, or tachypnea / 32 breaths per minute, and at rest. And then you'd walk, or you'd have them do their little activity, increases to 36 breaths per minute with sandwich prep. And that'll indicate to the reviewer, man, she's quite dyspneic. Look at their chest size and shape. A normal chest shape is rectangular. Now, we don't mean the boxy shape, but if you look at somebody from the side and from the front, it should be, you got your shoulders, it comes down and to the hips, or from the side, you've got the front to the back, and it comes down. It should be fairly equal, because the erect posture, and minus a kyphosis or a scoliosis, it should be rectangular and down to the hips. If somebody has a barrel chest, the front view, if somebody has a barrel chest, they're going to have an apple-shaped chest, and then it's going to kind of come sharply down to the waist. And the same from a side view, it'll have that apple shape at the top, and then the smaller waist. So again, a lot of these things I'm pointing out as individual things, and it sounds like a lot of things to look at, but after you get experienced at looking at someone who has COPD, emphysema, breathing problems, you'll notice these things instantly, and it takes longer to write them than to notice them. So you may want to get a check sheet so that you can just check barrel chest, scoliosis, forward head, flared nares, furrowed brow, all those things, and you can certainly do that to make it easier. So it's just a check sheet. What was the other thing I wanted to mention? Well, it left me. Just the chest size and shape. Is it a normal rectangular, elliptical shape, or is it more of a top heavy? Oh, I know what I wanted to say. If it is, then you're trying to decide, do they have kyphosis or do they have a barrel chest? And you might think, well, shoot, I can tell that. Well, what if they have both? What if they are elderly and they have osteoporosis and COPD, which a lot of the women may. One way you can determine which is the predominant, or which it really is in a kyphosis, the spine has curved, and it's decreased physiologically, mechanically has decreased the space that the lung has in which to expand. So you should be able to see. I've moved with my camera down here. Well, now I can't see what I'm doing. I can't see what I'm doing. You should be able to put 3 fingers between the lower rib and the top of the hip bone, the iliac crest. If they are so kyphotic that it's decreased that space, you won't be able to get three fingers between there. So if you can't get 3 fingers between the lower ribs and the top of the hip bone, then it's kyphosis. If they've got that apple-shaped chest and you can get 3 fingers between the lower ribs and that hip bone, then it's probably emphysema, barrel chest. Just a little side note. Okay, some common chest deformities, and I say common, and this isn't like every third person has it, but there's a deformity called pectus excavatum, and an unkind layman's term for it is funnel chest. And I don't know if you can see, I don't know if I put this up here, if you can see it. Here's the picture of it. But it's the sternum is depressed. And I have a niece who has a mild case of it. She's 9. And it was present at birth. And the pediatrician looked at it and said it will not cause a problem. It can be so severe that it puts pressure on the heart. And it is a problem then. And needs to be surgically corrected. Although there are some, that go through childhood and for whatever reason, lack of medical care, it does not get corrected, and it can cause arrhythmias, insufficient blood perfusion, blood flow in later years. And one of our speech pathologists, her husband has pectus excavatum, and it is causing health problems now at 42 years old. And the surgery to correct it is horrendous. Basically, they break the sternum and put a rod horizontally across the chest to hold the sternum off of the heart, and it's very painful. And if they ever have to take the rod out, they're back to square one. So it's a bad condition if it's a severe case. The opposite situation is called pectus carinatum, or pigeon chest, and that's, well, let's see if I can get it over here. So the sternum flares outward. I'm sorry, I'm wiggling this around. So it's almost like the xiphoid process is prominent at the skin, and there's not much skin coverage at that, over the tip of the xiphoid. And when I've done this course before, several people have spoken up and said that their cousin, their brother has that. There was a patient at Stanford, a female, who had it, and she said it's real tender. So like when she wore her bra, that it's just very tender. Which again, I guess because there's not much tissue coverage, it's hard for, or it's uncomfortable for things to touch that. But as far as a physiological problem for the heart, the lungs, it's not a problem. But so breathing patterns, we're on to that. Diaphragmatic breathing pattern. The stomach rises on inhalation. So we're going through these again so that you'll be able to use the correct physiological terminology when you're describing someone's breathing pattern. So you say someone uses a diaphragmatic breathing pattern, which is the best breathing pattern. A paradoxical breathing pattern is not good. A paradox is when something is not as it should be or as it appears. So a paradoxical breathing pattern is when the stomach rises on exhalation. So a diaphragmatic breathing pattern is when the stomach rises on inhalation. And that makes sense because when the diaphragm contracts, it pushes down against the abdominal contents, and so the abdomen rises because the contents of the abdomen have to go somewhere. So a paradoxical breathing pattern, the abdomen rises on exhalation, and that's because the diaphragm is ineffective, and there's a negative pressure. I'm saying this wrong, but I think if I remember right, it's because there's a negative pressure created in the thorax, and the diaphragm moves upward instead of downward during inhalation. So you've definitely seen people who have a paradoxical breathing pattern when they're sitting in their chair, and it just looks like they're breathing wrong. It's hard to, when you breathe right, to mimic it, but when you see it, you're like, oh, that's what that is. That's the paradoxical breathing pattern. If you want to see it, there's a sad example of it on YouTube. It's called, just put Philip asleep, or paradoxical breathing, and then when it comes up, it's called Philip asleep. It's a baby who has paradoxical breathing. It's a seesaw motion of the upper and lower of the chest and the abdomen. Okay, then there's asymmetrical breathing, and the sternum and the belly button will pull to the stronger side with a deep breath. You may see that with a stroke or with neuromuscular diseases like ALS, Guillain-Barré. Lateral breathing pattern, kind of similar. They use one side more than another. They may do this with painful conditions if they've had a surgery or a gunshot or a fracture, that they just inhibit that side because it hurts, so they'll use the one side more than the other. Shallow, which a lot of our people do, shallow breathing pattern. So in order to give the body the oxygen it needs, they'll have to develop a faster respiratory rate. So you should see shallow respiratory breathing pattern along with tachypnea. Irregular breathing pattern. So they'll take some rapid breaths and then some slow, or they'll some some deep breaths, then some shallow. And then pursed lip exhalation. Or another version of that might be grunting or voiced exhalation, which achieves the same purpose. They're slowing the exit of air so that they'll have a more effective rebound for inhalation. They have an obstructive airway disorder. They're having trouble, they have trapped air in their lungs with emphysema. So they have to push to get the stale air out so that they can have rebound and take a deeper breath. I've got a note on here. If you want to see if people are using the accessory muscles, you can see the sternocleidomastoid, but really that's not the first accessory muscle to kick in. The first accessory muscle to kick in are the scalenes. And to palpate that, stand behind the patient and come into this triangle right in front of the sternocleidomastoid, and then just palpate. And if they're using their accessory muscles, you'll feel a contraction of that muscle. And don't freak out thinking, well, I don't know exactly where the insertion and origin is. If you just lay your hands in front of the sternocleidomastoid, shoot, Tammy. I'm sorry. If you lay it, say in front of the sternocleidomastoid, if you lay it in front of the trapezius, is where it is. I'm sorry, Tammy. If you lay it in front of because if you just go in behind them, it's a natural fit. If you just go in behind them and lay your hands on their shoulders, like you're going to give them a massage. So lay it right in front of their trapezius. You'll feel the scalenes contract if they are using their accessory muscles. And in the training I went to, if somebody's saying, I can't breathe, and you want to discern accessory muscle breathing from anxiety, do that. Palpate for these are the scalenes, and if it's anxiety, they will not be using their scalenes. So that's a little trick. Other observation, and this is more of a question. Ask them where do they sleep? And this would be on evaluation because you're going to know. Well, sometimes you won't know because we're not there on third shift. But ask them, where do they sleep? Don't assume that they sleep in their bed. We've had several patients at one of the facilities who were homeless, and they slept sitting up against a building. And somebody pointed out, in one of the trainings, that is a safety thing, that they don't lay down. It's unsafe to lay down to sleep. You sit up against the building in case somebody's going to rob you or attack you. So ask them how they sleep and what position they sleep in. Don't assume they get into bed. Don't assume they lay down. And then another note was if they have orthopnea, that it's difficult for them to breathe when they lay down, note how many pillows they need to be able to breathe. And I've never seen this, but when I went to the training, they said it's acceptable to classify it as 2, 3, 4 pillow orthopnea. Okay, we're on to the feeling section. We talked about palpating the accessory muscles, the scalenes, the sternocleidomastoid, even the upper trapezius, the abdominal muscles. Are they using their abdominals when they breathe? A way to palpate the abdominal muscles, see if they can do a sit-up. And we're not talking about the He-Man sit-up with their knees bent and in supine. But a simple way is put your finger under their lower rib and then ask them to start to do a sit-up or even just raise their head. And if when they do that, your fingers don't pop out from under their rib, they have 0/5 abdominal strength, because that movement should contract their abdominal muscles. And if it doesn't, they have if they can raise their head, it's 1/5 abdominal strength. We've already talked about this. Feel their rib spacing. Can you get your fingers in between ribs 8, 9, and 10? And then when they move to the side, can you feel that spacing, or is it just as tight as it was when they were sitting straight? On one of the earlier slides, we were talking about can they move sitting on the side of the bed? Can they sit? Do you feel the rib spacing? Can they move their arm? Can they move out of that position? So they're sitting on the side of the bed. Then ask them to move. Can you touch my hand here? Can you reach here? Can you reach your knee? Can you touch over here? See how can they move in space, or is their balance, their inability to breathe and do something at the same time an issue? Because it might be all they can do to brace their hands on their thighs and breathe, and now you're asking them to lift a hand and reach. They might need that framing to be able to push off of, to get diaphragmatic contraction to breathe. Check for asymmetries and abnormalities by palpating. We have found fatty tumors, pain. If you're having trouble breathing and you're using all these, accessory muscles and splinting yourself to breathe, chances are you've got trigger points, sore areas in the trunk, in the ribs, in your back. So, palpate along their sternum, go up along, and this will just take you a minute. Palpate along their sternum, along their clavicles. Several times we have found old fractured clavicles. We found a separated acromioclavicular joint. So you'll be surprised what you'll find. And go along their acromioclavicular joint, then go around the back, palpate along the my memory's failing me. Suprascapular spine here. Then go down the vertebrae and out along the ribs. Like I said, we have found fatty tumors, lots of trigger points, and so you may find areas that need to be treated for pain and need to be reported to nursing. We found a skin cancer that needed to be attended to. Now we want to talk about where the lobes of the lungs are. I have looked high and low for good diagrams of where the lung lobes are, seeing from the outside, and I like this one the best. And I will have to, if you will, contact me when you finish watching this, and I will send this to you. But I'll show you. So take a look at this, and just contact me and say send the diagram. But basically, on the front of the chest, these are the upper lobes. So above the nipple line, these are the upper lobes. Tammy. These are the middle lobes, right at the nipple line. And basically, just to say you can't listen to the lower lobes on the front with. Now you can a little bit. So if you want to say, okay, lower lobes, and then okay. So then on the back is very simple. Upper lobes, lower lobes, and then on the side, axillary line, lower lobes. So when you're listening with your stethoscope, let's for our purposes, because we're not respiratory therapists, we're not pulmonologists. Upper, middle, lower, upper, lower. And like I said, some other diagrams that I have found online are more complicated, but this one made it simple and easy to remember. So I think that I can get that diagram to you if some of the some of your colleagues don't already have it from having listened to this training in person. Okay. Techniques for assessing chest movement. You can put your thumbs together at midline and spread your fingers out across the lower rib cage, and then ask them to take a breath in and exhale. Take a breath in and exhale. And you'll want to do that probably 2 or 3 times, because the first breath or two, they're trying to get used to what you're, figure out what you're doing, and they're not going to take a deep breath. So you'll need to do it several repetitions. And what you're feeling for is symmetry. Are they taking the deepest breath they can? And are they exhaling deeply? And you're not really going to take a measurement of this. Some texts or sources say to measure how far apart your thumbs move, but that is so subjective, because did you roll your thumbs? Did you kind of subjectively move them further or lesser apart, depending on how hard you think the patient's trying or whatever? I really think the best technique for measuring chest movement is to use the tape measure around the xiphoid process or around the nipple line. And normal chest expansion is 2 to 4 inches, 5 to 10 centimeters. So if whichever you'd like to record in, 2 to 4 centimeters. And I guarantee that you will be, once you start measuring these, I'll be very surprised if you get expansion greater than half a centimeter, 1 centimeter. It's amazing. And then I think about, it's like putting a gate belt around your chest and then trying to walk, do all these activities with that gate belt around your chest. I don't know how these people do their activities with that limited respiratory function. So that kind of goes over the placing the hands over the lobe you wish to assess. So this gets in the technique for assessing chest movement. If you have a lobe, so you've determined, so you've assessed symmetrical movement, and you've determined, oh gosh, this right side is not moving as much as the left side. So now you put your hand over that segment, and you tell them to now take a deep breath, now exhale. And you might even give them some tactile pressure for some proprioceptive input. Now take a deep breath, now exhale. Take a deep breath, and you could say, initially, you could document initially very little movement in the right lower lobe, or with PNF techniques, increased expansion with repetition and cueing. Then you'll progress to whatever your coughing techniques, or is this a fly or a bee or something? And then assess the effectiveness of your cueing and your PNF techniques. Then assessing the diaphragm, same idea. They're going to be in sitting or semi-Fowlers, and you're going to put your hands in this position, or you can put your hand like this over their epigastrum, which is the area just below the xiphoid, and apply some pressure and tell them to take a breath. And what you're looking for is, does the epigastrum, does the abdominal area rise, or is it does all the breath exchange happen up in the upper chest? So this gets into the later modules about doing breathing retraining, but here you're just assessing. So when they take a breath, does the epigastrum, does the abdominal area rise, or is there no movement at all? And then you'll note that, because remember, this is, I move right on into treatment, but this is the assessment section. So you're just assessing whether the diaphragm moves. Okay, that is the end of Module 5, Chest Assessment. Thank you very much.